Good afternoon and welcome to the latest Milwaukee Press Club virtual Newsmaker. I'm your host, Milwaukee Press Club President Corey Hess from Wisconsin Public Radio. I have Medical College President and CEO Dr. John Raymond as our guest. He will be interviewed shortly by a panel of journalists. But first, I would like to thank our sponsors. Our presenting sponsor is Spectrum News One. Our sustaining sponsor is Miller Quass. Our event partner is WisPolitics.com. WisPolitics partners with the Press Club for this luncheon as part of its ongoing event series in Milwaukee, which is sponsored by UW-Milwaukee, Wisconsin Academy of Global Education and Training, 1125 at Pabst, Milwaukee Police Association, the Firm Consulting, the Medical College of Wisconsin, and Spectrum. Once again, today our guest is Dr. John Raymond. Dr. Raymond has led the medical college for the last 10 years. Under his leadership, the school has begun addressing Wisconsin's pending physician shortage by establishing 2 regional medical school campuses in Green Bay and Wausau. The medical college has also opened a pharmacy school. Since March, Dr. Raymond has become a recognized authority on COVID-19 and its impact in Wisconsin. This week, he was also recognized as a 2020 Executive of the Year for his leadership during the pandemic by the Milwaukee Business Journal. Congratulations, Dr. Raymond, and welcome. Thank you for your time.
Thanks, Corey, and it's really an honor to be here today in front of the Milwaukee Press Club. So many of you have really stepped forward to be sources of truth during the pandemic, and I just want to say thank you for that. 2020 has been a difficult and unprecedented year for our world in terms of multiple challenges. We have a deadly pandemic unlike anything we've experienced since the Spanish flu epidemic of 1918 and 19. Economic challenges that are similar in magnitude to those that were posed by the Great Depression that started in 1929. And racial discord that's been exacerbated by the disproportionate impact of COVID-19 and the economic downturn on people and communities of color. Now, we have made some progress in dealing with these 3 simultaneous crises, despite a number of daunting challenges. The challenges include the stealthy nature of the COVID-19 virus, which spreads easily and silently before patients develop symptoms, the lack of a comprehensive national plan to deal with the pandemic, politicization of public health measures, a slow ramp up of testing, rampant disinformation and inconsistent messaging about COVID-19, and a lack of awareness of the close correlation between the health of our people and the health of our economy. Now, some sectors of our economy are in extreme jeopardy because of those factors, and the pandemic has surged relentlessly through the United States, now having claimed over 260,000 American lives and straining the capacity and capabilities of our health systems throughout the country. But despite those challenges, some sectors of the economy have shown some unexpected resilience, and businesses have been forced to innovate, to survive, and in some cases even to thrive. We've developed a growing set of modestly effective therapeutics against COVID-19. We've learned as healthcare practitioners how to better support patients with COVID-19 and keep them out of the hospital. And we've developed multiple vaccine candidates that show promise beyond anything that we could have reasonably hoped for even a month ago. So I think we can see light at the end of the tunnel, but the tunnel is still very long. Now, my organization, the Medical College of Wisconsin, hasn't been immune to these 3 simultaneous crises. We've had to protect our employees, patients, and learners while trying to preserve our core business functions. We've had to deal with tremendous financial challenges as well, which might be a surprise since we're also a healthcare organization. But we had to cancel elective visits, surgeries, and procedures in March, and our clinical activity is really our lifeline. And grappling with difficult, emotional, challenging discussions about racial equity and inclusion, which are key issues here in our region. We've made difficult decisions, but we've moved ahead with clear communications, decisive actions, and a commitment to what we refer to as our 3 R's: remedy, recovery, and reimagining our organization simultaneously. And MCW, like many other businesses, will need to be a different organization on the other side of COVID-19 than we were in February of 2020. And we need to be different in ways that make us better and reflect our core values. And I think that's a plan that our state, our country, and the world should embrace. Again, I want to thank our press and the media for being sources of truth, objectivity, and rationality at our time of great need. So thank you, Corey, and I'm happy to answer any questions that you might have.
Well, thank you. So let's hear from our panel of journalists. Today we have Sophie Carson from the Milwaukee Journal-Sentinel, Rich Kirchen from the Milwaukee Business Journal, and Shmaine Mills from the Wisconsin Public Radio. So here we go.
Hi, thanks so much for being here, Dr. Raymond. My first question is in regards to the hospitals. We've heard that even if hospitals can find space for more beds, the severe staffing shortages they're facing really present an insurmountable challenge. So is this true in southeastern Wisconsin as well? And what do you foresee in the coming months in terms of staffing?
Yeah, thank you so much for the question, Sophie. The situation here in southeastern Wisconsin is very similar to what it is in the other 6 regions of the state. The hospitals have been running about 90 to 92% full for the last several weeks. Now, I want to be clear, only 31% of the hospital beds are filled with people that are in the hospital for COVID-19, but other illnesses don't stop. When we have a pandemic like this. And this has strained our capacity. Our intensive care units also are running at 90 to 95% full. We were at 95% full in southeastern Wisconsin in the middle of last week. And that's always a problem for us because these facilities are really meant to function optimally between a 75 and an 85% occupancy rate. Now, you did mention one of the major limiting factors. It really isn't our beds. We can manage by creating internal surge capacity, but if we don't have a staff to staff those beds, it's really difficult to take care of everybody, not just patients with COVID-19. And it is true that hundreds of healthcare providers are out sick with COVID-19 or in quarantine because they've been exposed to somebody that has COVID-19. And this has been a challenge for us. This actually started first in northeastern Wisconsin, then spread to north central, south central, and then recently here to southeastern Wisconsin. So this is a challenge for us. And Sophie, what I would say is, what are we going to be dealing with in the next few months? It largely depends on individual choices that people are going to make throughout the holiday season. I know that this is a difficult time for us. We're 10 months into the pandemic. People need human touch. They've been isolated from each other and from their families. But where the pandemic is actually taking hold right now is in small family gatherings and leisure time activities. And as we enter the holiday season, if people ignore the recommendations of our public health officials, it's very likely that we will overwhelm the capacity of our health systems to take care of everybody, whether they have COVID-19 or not.
Thanks so much, Dr. Raymond. Rich?
Hi, John. Thanks again for doing this. You're a busy guy with all of your media appearances these days. I've noticed, and I'm sure everyone else has, that, and I have not seen the number for today, but the past few days, the number of hospitalizations actually declined a little bit. Still, these days, the last week or two are still are the highest of the pandemic for hospitalizations, but and also some of the new case numbers were down. What do you read into that? Does that have any significance, or what's going on there?
Yeah, thanks, Rich. Let me start by saying the burden of disease in every county of Wisconsin is very high right now. And I think we're all looking for signs that we may be turning the corner. And there are some preliminary signs, but 3 or 4 days doesn't really make a trend when it comes to COVID-19. So let's just begin there. But you are right. The hospitals peaked at almost 2,300 patients with COVID-19. I think 456 of those were intensive care units last week. And we're down about 10% from both of those numbers now. So that's potentially a good sign. But I think it highlights the importance of personal responsibility as we go into the holidays here. We have a very thin margin to work with. And it is not an exaggeration to say that our healthcare providers are the limiting factor. and none of them are living in a bubble. If there's rampant community spread, they're very likely to become sick with COVID-19 or to be exposed and not be available there to take care of people. So some other potentially promising signs, the reproductive number, which is a measure of contagiousness, which ideally you want to be below 1, has been above 1 for several months, but now appears to be trending down close to 1. And so, again, don't want to overinterpret, but there are a couple of very early indicators that we may be peaking, at least here in Wisconsin.
Any idea why that might be? That we're peaking and then, maybe showing improvement?
Again, this is speculation, but the more people that take the pandemic seriously and behave with individual responsibility, the less likely it is for the virus to spread. Everyone needs to remember, human beings are the host and the vector for spreading a lethal, silent virus. And the most important variable right now is our own behavior. Therapeutics that are coming along are modestly effective. They're going to help us. But the most important tool we have is how we behave and sort of own that responsibility.
Okay, Shemaine.
Thank you. Dr. Raymond, I'd like to talk about deaths. You said the treatments are modestly effective. They're largely experimental. Deaths keep increasing in the state, but the rate of fatalities linked to the disease isn't as bad as it was early in the pandemic. Is this due to treatments, more testing, or what do you attribute it to?
Yeah, thank you very much, Shemaine. And I think you've answered the question partially already. We have much better and more widely available testing now than we did early in the pandemic. And if you can detect cases earlier, you can intervene earlier. And we do have some modestly effective therapeutics. We also know a lot more about how to take care of and support patients that have COVID-19. So for example, early in the pandemic in Italy, New York, New Orleans, people would intubate patients when their oxygen saturation got into the 80s. That's typically what we do for respiratory failure for other diseases. We now know that that's actually not the right thing to do. So interventions like having patients lie on their stomach, this is called proning, can help them keep their lungs inflated and perhaps avoid having to be intubated. We also know that we can support those patients with high flow oxygen delivered either by a mask or nasal cannula rather than having to intubate and mechanically ventilate them. So those breakthroughs have been very, very important. I also would say there is a growing awareness that people that wear masks not only are less likely to be infected by COVID-19, but there's also this idea that if you do become infected, you may inhale a smaller dose of the virus because of the mask and therefore not overwhelm your immune system early on, and that maybe you have less severe disease. I think there are multiple factors for why we're doing better. Shemaine, if I could, I just want to say though, that still the final predicted death rate or the case fatality rate for COVID-19 is likely to settle in somewhere around 0.7%. So a lot of people will take comfort that it's less than 1%. That's still a lot of people. We have 260,000 plus deaths in the US right now. And I also want to point out this is 5 to 10 times worse than a bad year of seasonal influenza. And then finally, many people that have COVID-19 and are characterized as recovered still have what is called long COVID or long hauler syndrome, where they have symptoms that may be debilitating and limit their activities of daily living and their ability to go back to work.
So you expect us to go down to 0.7. Right now we're at 0.8 statewide, but some counties like Florence County, I think they're at 4% of the patients with COVID are dying. Why is that?
I think in the US, again, and it's hard to measure these things until after the pandemic is over, but many epidemiologists are predicting a 0.7% fatality rate. What happens though is in health systems that are new to treating COVID-19, there's a learning curve. And there may be a learning curve in the community as well, where people don't come to the hospital until they're really gravely ill. There may be a mismatch between the availability of testing sites and where the cases are flaring up. So typically what you see early in an epidemic is a very high fatality rate. And then as the epidemic spreads throughout a country, throughout a state, as you get later in the epidemic or pandemic, the fatality rate goes down. So I do fully expect that at some point we as a country will end up being in that 0.7% range.
Sophie?
Thanks so much. So on the topic of hospital staff, once again, DHS Secretary Andrea Palm has said that the competition for nurses across the country is ramping up as the pandemic gets worse across the country. And so Wisconsin will have a harder time getting healthcare workers to come here to fill the gaps. To what extent have traveling or out-of-state nurses helped fill the shortages so far? And how much are hospitals relying on those types of nurses?
I think it's a really good question, Sophie. My belief is that we really aren't bringing in people from many other states because COVID-19 is surging across the entire country. And so this is different than the situation that was experienced early in the pandemic in New York, New Orleans, Texas, where they could recruit talent from parts of the country that weren't impacted. If you look at the map of the US, the states that had the early burden of disease are starting to surge right now. So nurses from New York are less likely to want to come to Wisconsin or Montana or South Dakota, some of the hot spots, to really provide care for us. And I really appreciate you mentioning nurses because it's important. I mean, when we think about talent, a lot of times people start with physicians, and certainly they're important, but nurses and respiratory therapists, physician assistants, those are the frontline healthcare providers that are most deeply impacted by COVID-19, and they are our limiting factor in the ability for us to take care of everyone.
Thanks so much, Rich.
Thanks, Sophie.
John, in the last couple of weeks, the healthcare systems in around the state and certainly in Southeast Wisconsin have announced that they're reducing, going back to not an entire shutdown of elective procedures and surgeries like we had in March and April, but some level of reduction. I'm trying to remember, I think Advocate Aurora said something like 50% reduction. Freighted and Ascension, ProHealth are all looking very carefully at whether they, absolutely need to do a surgery or a procedure. How much, is that needed? Does that help some with what we're talking about here on the capacity issue?
Yeah, thanks, Rich. It does help. I mean, generally what you end up doing is you try to uncomplicate the frontline healthcare situation and to provide surge capacity by repurposing an operating room, recovery room areas, procedure rooms to be intensive care unit beds or hospital beds. You can do that for a month, maybe two. The system is fairly resilient, but it's not a good long-term solution either for the financial health and well-being of the health systems or for our ability to take care of chronic diseases that aren't COVID-19. So really, these are temporary interventions. Rich, you and I have talked about MCW's challenges early in the pandemic. We provide most of the specialty care for Freighted and Children's. And when elective procedures were shut down by CMS in mid-March, we went from what was looking like a year in which we would have a $40 million net positive margin to potentially looking at $100 to $150 million loss, and had to deal with that in a 2 to 3 week period of time. And so these elective procedures are truly the lifeblood of the finances of most of the health systems.
And now with the current reductions in those elective procedures, what kind of financial impact are you anticipating?
Well, so far it's been minimal. And again, there is the opportunity to convert some visits to virtual modalities And, as you know and have reported on, many of the health systems were able to pivot pretty quickly to virtual modes. So that gives us a little bit of a buffer. I also think that, again, we learned early in the pandemic how to repurpose staff, how to optimize the efficiency of our clinics, how to preserve our personal protective equipment, which early on was one of the limiting factors. And it still is a limiting factor, but we're much better about applying what I would call manufacturing engineering principles of trying to maintain maximum efficiency. So, I'm confident that barring another huge surge associated with holiday activities, that our health systems have the resilience to be able to deal with it. The other two things that have changed here in southeastern Wisconsin, Rich, since the first surge in the pandemic, is we do have the alternate care facility. And I want to make sure that everyone knows we have an extraordinarily competent team running the ACF. Deb Standridge is a very experienced, very competent executive that used to be with Ascension. She and her team are doing a fantastic job. But everyone needs to understand the ACF really is there to decant patients to open hospital beds in the full service hospitals during the last 1 to 3 days of an anticipated hospital stay. They are improving and enhancing their ability to provide supportive care. They can now provide high flow oxygen in most of the beds. They can go up to 530 beds. They are able to give remdesivir now, infusions, which has been very helpful in getting patients out of the hospital. And they've upgraded some of the beds to full hospital beds rather than army cots, which makes it a more desirable place to go. And they're continuously upgrading their capacity. The second thing that's happened, and again, I want to thank Peggy Troy and the leadership at Children's Hospital for being willing to expand their footprint by taking patients up to the age of 26. To try to relieve the pressure on the adult health systems. And they'll do that for anyone that wants to transfer patients there. They're not going to take patients with an active COVID-19 infection or diagnosis, or patients that have influenza. They're not trying to bring those diseases into the clinical care environment. They really want to bring patients in with chronic diseases, with an acute exacerbation that the clinicians are comfortable taking care of. So non-coronary heart diseases, some cancers that affect adolescents and young adults, asthma, pulmonary diseases, infectious diseases. Those would be the types of activities. We simply didn't have that capacity early in the pandemic. So that gives us a little bit of a margin of error that we didn't used to have.
All right, thanks, Shemaine.
Dr. Raymond, I'd like to talk about vaccines. We could have one approved in the coming months. It's been said of vaccines, nothing. Vaccination is everything. How do we get those who are expected to be the first to be offered a vaccine, healthcare workers, to actually take it? I mean, I have been at legislative hearings where hospitals wanted mandatory flu vaccinations for their workers, and they were always heavily opposed. So is it going to be the same thing with a COVID vaccine?
Well, that's really a tough question. And, really for us to get on the other side of the pandemic, we need good vaccines that are widely available and that people are comfortable taking. I actually think that the two vaccines that are based on mRNA technology, the Pfizer vaccine and the Moderna vaccine, are better than we could have dreamed of a month ago. The preliminary results, we would have been happy with a 50% efficacy at preventing infections, and we got 95% for both. That is truly remarkable. Now, what I think people may be concerned about is safety, because typically we have at least a year's worth of experience with a vaccine on hundreds of thousands of patients before it's approved for marketing. In these situations, we're really going to be going on a couple of months of experience with 30 or 40,000 patients that got the vaccines. But I think the good news is, even though the mRNA vaccines are a new technology, there really haven't been major adverse events associated with the first 50 or 60,000 patients that have gotten the two vaccines. So I do expect that on December 10th, the FDA is very quickly going to authorize an emergency use authorization for the Pfizer vaccine. I hope that Moderna will submit their EUA sometime this week and will be approved in mid-December, and that we'll be able to have 20 to 40 million doses that are provided for frontline healthcare providers, first responders, and nursing home patients in that first wave. I actually believe that we will have 100 to 200 million doses of those RNA vaccines available by the end of January, early February at the latest. And it's very likely that the AstraZeneca vaccine, which also at least one of the dosing regimens has a 90% effectiveness, could be available in the first few weeks of January. And then the Johnson & Johnson vaccine could be available also sometime early in 2021. So, but as you said, we really have to get people comfortable with the fact that the risk of taking the vaccine is small compared to the risk of getting COVID-19.
Do you know of any hospitals that have done surveys of their nurses, doctors, other staff to see if they would take COVID vaccine?
Yeah, I'm not aware of that, but what I can tell you, Shemaine, is we make taking the influenza vaccination mandatory at the Medical College of Wisconsin for everybody because we can't really separate frontline healthcare providers from all the other folks that work here. We do have an exemption process that's based on medical exemptions, but we really don't give many exemptions each year. My expectation, though, is for lots of reasons, it'll be difficult, if not impossible, to make taking this vaccine mandatory, even for frontline healthcare workers. Again, because we don't have the typical 1 year of experience on hundreds of thousands of patients. Now, if we end up needing booster shots every year with a COVID-19 vaccine, it's very possible that late 2021 or 2022, we could make those vaccines mandatory, but I just don't think we're going to be able to do that early in the pandemic.
Sophie?
Thanks so much. On the topic of the field hospital alternate care facility at State Fair Park, you talked about that a little bit and how they're expanding their criteria. But how do you perceive the usefulness of the alternate care facility? Is there a future where all 530 of those beds are being used? And how helpful would building regional field hospitals be, as was mentioned by the Wisconsin Hospital Association earlier last week?
Yeah, thanks, Sophie. I think the answer to the question depends on what happens in the coming months. If we maintain a steady state where we are right now, I do think that the field hospital has utility. To a person, the leadership teams of Southeastern Wisconsin's healthcare systems have been very grateful for the work that the ACF team has done. And it has allowed us to free up hospital capacity to take care of other patients. Not necessarily so much when people have to travel 3, 4, 5 hours to get here. That's been a barrier. If things get much worse, I believe that we might need more than the current capacity of the ACF, which I think is somewhere between 50 and 60 beds that are currently staffed. I sure hope that we don't get there. If we do have an overwhelming surge, the idea of field hospitals throughout the state has some merit, but I think what we need to consider is whether we'll be able to staff those facilities. We're having difficulty staffing the frontline established full service hospitals. It might be difficult to staff field hospitals that are distributed throughout the state.
Thanks so much, Rich.
Thank you.
Dr. Raymond, you talked about the medical college's policy as far as your own employees and the flu shots, and then looking at what it might be with the vaccine for COVID. What are your thoughts on employers overall or in general, and the role that they need to play or that they could play with getting their workforce vaccinated, and any thoughts about whether an employer could make it mandatory for people to get the shot before returning to the workplace?
Well, thank you, Rich. Let me start by saying I'm not an attorney, so I can't weigh in on whether employers can mandate the vaccination. We have internally had conversations with our legal team and our ethics team about it. And right now we're leaning toward not being able to mandate that early on. So I'm sure other employers would have to go through the same discernment process. Look, I have to say our employers And I want to give a shout out to the MMAC and the WMC, have been outstanding in terms of trying to provide safe workplaces for their employees and to provide safe purchasing environments for their customers throughout the pandemic. And obviously not every business falls in that category, but most have been incredibly responsible. And most recently, when the spread of COVID-19 has really been happening in homes and in small family gatherings, the employers have tried to help make sure that their employees tried to practice the same diligence at home that they practice in the workplace. So I want to make sure that everyone knows we have very responsible employers in Wisconsin, and they have been and will continue to be part of the solution. I think they could help convince people that the risk-benefit ratio is favorable. And one underappreciated aspect of what a lot of our employers are doing to help control the pandemic is, when we reach the surge levels we have right now, our public health infrastructure simply can't do contact tracing to the extent that we would like. And that is a real problem for us. Many employers have dedicated contact tracing teams internally that have really helped us identify at-risk people and made sure that everyone understood what the CDC guidelines are for quarantine if you've had a documented exposure, and for isolation and return to work if you have a COVID-19 infection.
Okay, thanks. Charmaine?
Thanks, Rich. Doctor, in your opening remarks, you talked about disinformation during the pandemic. What about some messaging issues from health officials and the media? Are the words or phrases that you particularly like or thought were inappropriate? For instance, the term social distancing has taken a lot of flack.
Yeah, maybe physical distancing is a better term because, COVID-19 makes us stay apart, and that socialization aspect is important. All I can say is we have not communicated enough and consistently enough in ways that people understand to get the kind of traction that we need. And I think it's hard to overcome the misinformation, the disinformation, the conspiracy theories that run rampant on social media. I can say every time we post something simple like follow the 3 W's and be careful over the holidays, there's pushback from people that just simply think that we as healthcare providers have some devious agenda that goes counter to their beliefs about freedom and the virus. And it really is just a huge challenge. I think people believe frontline healthcare providers more than they necessarily would believe an administrator or an elected official. But I think we're now at a phase where we need public figures who are popular and have their own followings to embrace the ideas of personal responsibility. Again, COVID-19 looks at human beings as the host and the vector for transmission. And, we are the people that can prevent that.
Sophie, you're next.
Thanks. So could you talk about the kinds of resources and staffing that an ICU patient requires? When we say a handful of ICU beds are left available in a region, what does that mean in practice?
Thank you, Sophie. Let me just start by saying that it's pretty difficult for us to think about a regional or statewide intensive care unit strategy. It's very difficult to transfer a sick patient from one hospital to another or one health system to another. So a lot of these issues actually are microenvironments of that particular hospital. We're blessed in southeastern Wisconsin by having large, capable health systems and large hospitals that have the flexibility to flex up and flex down. So even though we may just have a few ICU beds left, there's a limited capacity to repurpose other beds. That's difficult for the northwestern and western parts of the state because they just don't have that many ICU beds to really flex up and flex down. And what I would also say is ICUs run best when they're 75% full. Staffing, the economy, the ability to effectively get people in and out, things start to break down when you get up over 85 or 90%. So there's the length of stay increases because it's hard to turn people over in the ICUs. It's hard to fully staff for days on end when people are taking extra shifts. So all these little things add up and make it just more challenging to take care of everyone.
Thanks, Dr. Raymond. Rich?
Thank you, Sophie.
Dr. Raymond, you mentioned that hospital and healthcare systems are financially and operationally resilient, when there are these short periods of suspending procedures and surgeries, elective procedures. So the for the spring quarter, which was ended June 30th, healthcare systems and your organization took a hit. But then the most recent quarter, September 30th, I looked at the numbers today, and you were in the black. I think close to 10 million, revenue in excess of expenses. What do you attribute that to? Was that because you were able to resume those procedures?
Yes. First of all, the first quarter of the year is when MCW generally makes our margin for the year, and we progressively erode that over the rest of the year for lots of reasons we don't need to go into. That's actually not a very good quarter for us. So let me just start there. But to answer the second part of your question, the resilience that we've been able to show has to do with discipline in managing our supply chain, keeping our expenses low and manageable to the extent that we can, in part deferring critical purchases to the future, which isn't a completely sustainable intervention, and resumption of many of our elective procedures. So our adult practice, which is primarily at Froedtert and within the Froedtert system, has bounced back to about 95% of pre-pandemic activity. Interestingly enough, that pediatric practice has been a little slower to bounce back, even though COVID-19 hasn't necessarily directly impacted the patients in Children's Hospital. So yeah, I would say that it's been the restoration of the elective procedures, increased efficiencies, and trying to reinvent and reimagine how we do business.
Okay, thanks, Jermaine.
Just, Rich, I want to make sure, we're still projecting a 0% margin for the year.
Oh, okay. For the new fiscal year?
For the entire fiscal year, that's our target. Typically, we have a 3 to 3.5% margin target. Our board recognized the extraordinary challenges that we have and agreed that we could try to have a break-even margin for this fiscal year, which was our revised target for last year.
Okay, good. Thank you.
Dr. Raymond, you talked a bit about lack of a broad pandemic strategy. I'm wondering, do you think local restrictions can be effective, or do people just move elsewhere or go elsewhere to do what they can't do in their particular community?
We do know that local and regional interventions can be effective, but they're not effective when the entire country is raging with a pandemic. Unless we stop travel like they did early on in China, and have the types of restrictions that Americans aren't used to and probably wouldn't tolerate, those local interventions are helpful, but they're simply not enough. And our real problem has been a lack of national coordination of the timing and the types of interventions that we had to try to slow down the pandemic. We don't have a national strategy for contact tracing, for testing, and those have not served us well. On the other hand, I do want to mention one thing that I think that we have done well, which was to invest in Operation Warp Speed. The US government took a gamble somewhat. They invested billions in research and development dollars for some of the leading vaccine candidates. Interestingly enough, Pfizer didn't take any of the R&D dollars, but I also thought it was a great leap of faith for the US government to pre-purchase vaccines before we even knew whether they were going to be effective. And as it turns out, that's going to probably be a very good gamble that ends up serving our country well. So that's an example of something that we could have done well with some of these other interventions, but didn't, because we largely relied on states and municipalities to do local interventions. And again, I just want to make sure everyone knows that COVID-19 doesn't respect county lines and state borders. It travels wherever people travel. And that's been one of the flaws in how we've tried to stop the pandemic, by focusing only on local interventions.
Thanks, Sophie.
Similar along those lines, how important a role could widespread rapid testing play in reducing the spread of the virus?
Thank you, Sophie. I think widespread rapid testing with high specificity and sensitivity, in other words, a small number of false positives and false negatives, could be a game changer for all of us. And antigen testing that measures protein from the virus probably is, at the end of the day, going to be a better solution than these PCR or the genomic tests that we have for diagnosis, although there is some progress there. If for $5 you can do either a saliva test or an anterior nasal swab, where you don't have to go very deep in the nasopharynx, which is uncomfortable and really makes it hard for people to adhere. If we could do that a couple of times a week, it could really change the way that we go about our daily activities, and it could restore confidence in travel, the workplace, going back to school. And we do have some tests that I think are likely to help us with that. And I'll name some companies because they're being used locally: Quidel, Becton Dickinson, Abbott Labs. All three have pretty good antigen tests that are relatively inexpensive, but the only one that doesn't require a proprietary instrument is the new Abbott antigen test, which uses what's called a lateral flow technology with a yes/no indicator that's a color indicator, like for a pregnancy test. So as those mature and become less expensive and more reliable, I think they're going to be part of our everyday strategy for at least the next 6 to 9 months.
Do you think that states or local municipalities should take on that burden, sort of to implement these rapid tests widely? Is that something that you're hoping takes place, or are you thinking more on the healthcare system side of things?
Well, in the ideal situation, we would have a national strategy with national interventions. I think a statewide strategy makes some sense, but again, our state borders are porous and people are going back and forth. So if you could get interstate collaboration on a plan, it would help. That really hasn't worked so far, so I don't think it's practical. So absent a national or statewide strategy, a combination of health systems, public health departments, federally qualified health centers, schools like the University of Wisconsin system, which does have a very robust testing strategy, sports teams, local school districts, all those things could work. But we don't have a good way of coordinating those right now, which is really one of our major problems. And then always the question is, whose budget does it come out of?
Right.
That's always a tough issue.
Right. All right. Thank you, Dr. Raymond. Rich?
Dr. Raymond, one of your long-running goals and priorities has been for the medical college to address health equity issues, the disparity in healthcare options and access for people in low-income areas, and you're involved with actual physical presence that's going to be opening up on King Drive in Milwaukee sometime in the next year or two. But any updates, any new developments with those initiatives?
Yeah, thank you, Rich. And we are deeply committed to Central City, Milwaukee, and the people and communities of color there that suffer from a disproportionate burden of health disparities and economic and other disparities. And we see strong linkages between economic issues and health. And we really have been trying to lead that conversation. We're blessed to have the Greater Milwaukee Foundation and Royal Capital Group as our development partners for the old Gimbel Schuster department store, which interestingly enough is 3 blocks from where MCW was founded in 1893. So we're kind of going back to our roots. We expect to be able to occupy the building in 18 to 20 months. MCW will move most of our large community-facing programs into that space. Greater Milwaukee Foundation will move all of their staff in, and we're going to have a lot of community-focused space. And we've been undergoing a process for the last 2 years where we have listening sessions about what the priorities of the neighborhoods would be. And after the Sherman Park civil unrest that we had 4 years ago, MCW had very intentional conversations with our employees and who lived in and around Sherman Park. And the two things that they advised us to do was to be more visible and more intentional and to listen. And that's what we've tried to do. And MCW and the Greater Milwaukee Foundation are making a generational commitment to be part of Harambe, Halyard Park, and the Brewers Hill region.
Thanks.
Thank you.
Are we getting close, Corey, to audience Q&A?
Hello. Hello. We have time for one more if somebody wants to ask another question.
Sure, I will. Dr. Raymond, we're coming full circle here. I'm going back to hospital capacity. You were one of the first to talk about it. Are you surprised it's taken till now for this to become an issue? And has Wisconsin ever had a similar health crisis where capacity was a problem?
Not that I'm aware of, but I've only been here 10 years. So I imagine we probably were challenged during the Spanish flu pandemic. That was more than 100 years ago. No, so this really is in many ways extremely unprecedented for us. Am I surprised? I'm not surprised that we're surging right now because there was so much skepticism, particularly in other regions other than southeastern Wisconsin, about the severity of COVID-19 and the usefulness of these personal interventions for a large part of the pandemic. And we were doing pretty well through September. But what I want to say is I am really proud of the way that Milwaukee responded early in the pandemic. We recognized an outbreak in largely African-American communities in Central City, Milwaukee. Many of the African-American faith-based leaders took personal responsibility for partnering with health systems and the community clinics to provide good, culturally relevant information from trusted sources. The community took their role very seriously, and Milwaukee really got on top of the pandemic very early. And that may have led to a sense of complacency in areas around us. And there also was sort of this idea that this was a Milwaukee problem. In the second phase of the pandemic in May and June, we saw spread in food processing facilities in southeastern and northeastern Wisconsin. Again, I don't think that the rest of the state felt like it was an issue for them. It was easy to say, that's an issue for Milwaukee. That's a nursing home problem. You're not focusing enough on nursing homes. You need to pay attention to prisons and food processing plants. It's really not going to come to me. And it really took the whole summer for COVID-19 to spread stealthily throughout the entire state. When students came back to the university in September, there was explosive growth of new cases, almost exclusively in the 18 to 24-year-old age range. And again, it was easy to say, this is a problem with college students. But 2 to 3 weeks after that, we saw a pretty significant rise in every other age range as those students interacted with their teachers, with employees in the community, and with their families. And now we just have a high burden of disease pretty much everywhere. As again, as I've said, every phase of the pandemic has had different drivers. And right now, I think we're in the most dangerous phase of the pandemic because this is happening in small gatherings and homes and during leisure time activity. And that really is the most difficult situation for us to control.
So I do have a few questions from the audience. One person asked several questions. I'll try to kind of put them together. They're wondering about burnout with healthcare workers, particularly nurses, but then all medical workers. And the person's also asking, what happens if nurses decide not to come in and you start running out of people?
Certainly, we hope that won't happen.
Yeah, let's hope. But what are you doing about potential burnout for workers?
Yeah, thank you for asking that question. You know, the burnout was already a major issue in healthcare, particularly with nurses, physicians, and other frontline healthcare providers. What I can say is MCW and our hospital partners have been very mindful about trying to provide enhanced mental and behavioral health support services. We have focus groups where people can kind of vent about their frustrations, respite areas where people can go to decompress. Freighter now has provided free boarding now for providers that are doing multiple shifts and are afraid to go home because they may take COVID-19 into their home. Free meals. These are new interventions that I think are important as we have the surge. What I would say is it's nice that the community calls healthcare workers heroes, and early on we're providing free food and things like that. It's more meaningful if people actually take their personal responsibility seriously. It is so frustrating for our healthcare providers, including myself, who have taken care of COVID-19 patients and see what a devastating and terrible disease it is, to see continuing disbelief in science and facts out there in the community, and a sort of flaunting of these social responsibilities that people could take. That does contribute to burnout and frustration. And I would hope that everybody understands we all have a responsibility, not just frontline healthcare providers. But I would also make sure everyone knows our healthcare providers are here to serve. They take their responsibility seriously. These are resilient, brilliant, driven people that want to do the best they can to take care of everybody. And they've not lost their commitment to that responsibility. Thank you.
Great, thank you. There's also a question, just sort of some practical advice about how hunkered down should we be at this point? Should we be getting haircuts, going to the gym, going to the grocery store? And then I'm actually going to piggyback on this one because I have my own question. Restaurants have been putting up these domes, these outdoor domes, so people can continue to dine. How safe are those?
I'm only going to be able to speculate because I'm not aware that any specific studies have been done. But unless there's good ventilation, they're only as safe as the people that you're with. And that would be the same advice that we would give for inviting anyone into an indoor space. And generally over the holidays here, we're recommending that people don't dine or interact with people who don't live with them. And that's tough for grandparents and relatives that want to get close to their families. And I would refer to what's called the rule of 6 in Great Britain. Basically, they're suggesting that people limit their circle of people that they interact with to no more than 6, and that your circle should include no more than 2 households. And I would even add that it's probably important for you to know how compliant are the people you're interacting with being with these regulations.
So are you saying no gym, no haircuts?
I'll tell you, I am not going to the gym. My wife cuts my hair, and we have not dined indoors at a restaurant since the beginning of the pandemic, although we are taking carry out from restaurants that we trust. And I know that's not, so I'm not telling people what to do. I'm simply saying this is what we do and we think it's the right thing to do. Just remember, the virus spreads in close quarters where you have poor ventilation, which is indoors and not outdoors, where you're crowded and are not wearing masks.
Given the skepticism that has grown out of racial disparities in the healthcare industry, how will communication with people of color be with the vaccine, and how do you think that will be disseminated?
Corey, I didn't hear the entire question, but I think what you were referring to as trying to build trust with communities of color about the safety of the vaccine, especially with the backdrop of the Tuskegee experiment and all the other terrible things that particularly African Americans, but other people of color have had to endure. That's a tough challenge. Again, I think that we're going to need to recruit trusted leaders from these communities who believe that it's the right thing to do to get the vaccine. And one of the things that I would say is our vaccine makers were very intentional about including people of color in the early studies to make sure that we could say with confidence that the vaccines have been tested in people like you, and they're safe and effective, so that we could at least take the science to another level than we normally do.
Thank you. I'm going to squeeze in one more. After healthcare workers, who do you think the next demographic will be that the vaccine is rolled out to?
Good question. There's an ongoing conversation about prioritization, but let me just start by saying it should be healthcare providers, first responders who really can't socially distance and may not be able to wear a mask and are touching people, and congregate living situations, especially nursing homes. Those would be the populations we absolutely have to start with. Then we're really going to have to think long and hard about essential workers, schools, communities of color, which in my opinion should be higher on the priority list than maybe some of the others. And so this is a complicated conversation that involves logistics issues, building trust, ethics, and I don't think the conversation is finished yet.
Well, again, thank you, Dr. Raymond, for your time today and this conversation. Thank you to our panel of journalists. And I'd like to thank our sponsors, Spectrum News 1, Miller Quas, WisPolitics.com. And if you enjoyed this program and are interested in supporting the Press Club, you can do so by going to MilwaukeePressClub.org and clicking on the MPC Endowment tab. And if you want to join the Press Club, you can do that also at MilwaukeePressClub.org. Please join us on December 3rd for another virtual Newsmaker event where we will have Milwaukee's hospitality leaders. So thank you all for coming today. And thank you again, Dr. Raymond, and our panel of journalists.
Thanks, Corey, Sophie, Shemaine, and Rich. Thank you.
Thank you.
Thank you.